My name is Joanna Chataway, and I'm Thematic Director of Social and Economic Inequalities, that theme, at the International Public Policy Observatory. I'm really excited to be chairing this afternoon's session and looking forward to hearing from our four speakers. Our speakers will go in the following order. We'll have Carol Vickers, who's a Senior Research Fellow at UCL's EPI Centre. Carol, I don't know how many years I've been working with EPI, and I still can't remember what EPI stands for, so maybe you could remind us when you begin your presentation what EPI stands for. We'll then have Sarah Arnold from the King's Fund, and Emily Andrews will follow from the Centre for Ageing Better, and we'll finish up with Daniela Silcock from the Pensions Policy Institute. And I will just say a little bit more about each speaker as they begin, just before they begin their presentations. But I don't think there's, I should say, you can use the Q&A function here on Zoom, and you can also use the chat function. So if there are things that occur to you as you're listening, please do put them in the Q&A or the chat. And also, if there are references that you'd like to make people aware of, references to other work, to other bits of evidence, please also feel free to do that. That can be really valuable for people who have joined this afternoon. So thanks very much. Let's get started. Carol, I'm going to hand over to you.
Great. Hello, everyone. I'm Carol Vigers from the EPI Centre, and it took me a good few years to work this out. This is the Evidence for Policy and Practice Information Coordinating Centre, which you might actually think is epic, but let's not talk about that too much. And we were charged with IPPO. We're both very interested in evidence for policy decision making, to do a rapid review of what evidence is there to support people who are sick, or people with disability, and older people return to work, and other employment-related outcomes in response to knowing that the increase in people in economic inactivity post-COVID hasn't seemed to have bounced back, and the people in this increase appear to be people who are with long-term sickness, people with disabilities, and older people. We had a think about our conceptual framework, what would be the scope of this review, and we were interested in looking at employment-related outcomes. So they were our first primary outcomes we were looking for. We would also include studies that reported other outcomes, such as quality of life or whatever, but they had to have an employment-related outcome. So that could be targeted for people either encouraging people to stay at work or return to work. It could be for people who are absent from work and then returning to work, or for people who may have been unemployed and looking at rates of employment after intervention. The interventions could be targeted at different domains, so they may be targeted at person-centered, and these are interventions that aim to change something about the person, with beliefs, attitudes, behaviours. They could be targeted at changing the context in which people work, so the workplace focused interventions. And around this, there may be structural interventions also that may lead to employment-related outcomes. And these were institutional changes or changes to structural, institutional, legislative policy changes further away from the individual, but still very much influential. And we were interested in, where reported, other factors may impact on these outcomes, such as family and caring responsibilities, skills and attitudes, demographic factors, perfect. So all of these are in scope of our rapid review. And quickly cover some of our findings. So just focusing on the reviews that were targeted for particular people, there were some common themes we found. So for people with musculoskeletal disorders, often the Office for National Statistics reported that this is a commonly reported condition for people who did report the condition for their signing off sick, one of the most commonly reported. But there were also reviews dealing with back pain, recovery from serious injuries. And there were common themes that multidisciplinary interventions were favourable compared to usual care, possibly outcomes related more favourable towards dealing with pain intensity and as other sort of health related outcomes, but less clear about return to work. But these tended to involving employees and health practitioners and employers all working together. So implementing work modifications and sort of job assessments, vocational assessments, as well as individually tailored interventions. So this was based on individual need rather than the diagnosis that they had, so very much tailored to the individual. For people with physical disabilities and or long-term illness and or disabilities, tailored workplace interventions and personal advisors and individual case managers. So again, working with sort of employers and individuals and health workers, or taking into account health conditions, working on particular needs of the individuals, but not based generic workplace interventions. We found one review that focused on young people with episodic disability, and for them these reviews favoured supported employment. Small to no effect were found for generic workplace interventions. Generic sounds like they were all the same, but the problem was they were also very different. There was a huge variety of different workplace interventions, from exercise programs to online support. They're so varied. Those reviews that focused only on outcomes regardless of the population tended to find smaller to no effects, rather than reviews that looked at targeted groups of people. Individual case management was interesting. That could be both positive and negative. So when done well, it works really well, and when done not so well, the not so well was one review of a UK-based intervention that found it was actually the delivery mode was maybe led to some unintended negative outcomes, such as working to targets meant that some people who are perhaps easier to place in supported employment were easier placed, and people with more complex needs may have been overlooked. So that can work for you, that can work against you for individual case management. For people with depression, common and or severe mental health disorders, again, ONS reported that people self-reported mental health problems is very common amongst those that were economically inactive due to ill health. We had some reviews for younger people, so young adults with a mental health condition which included severe. For them, we found interventions that individual placement supports were strongly indicated, sometimes with described as augmented support, but this was very much about sort of working with the employer to talk to tailor the workplace for the individual with support for both the work placement and the individual, and this was more effective in finding competitive employment, also improving quality of life and occupational engagement, often effective with combined with additional perhaps cognitive or social skills training. One example in the review was computer-assisted cognitive remediation therapy, which is designed to improve attention or concentration, memory, and so on. There's a small number of studies, but found to be effective for them. For several reviews to talk about with people with depression, but also work-related mental health, and burnout and stress at work, and also people with mild to moderate conditions, Again, the common theme here is multi-domain and supported. So working together with work-directed interventions, so modification of work environment plus healthcare, so clinical intervention, assistance in navigating services, so service coordination in combination with work modifications. Co-location of health services and employment services was found in a review of several rollouts of an intervention, mostly in Australia. So context should be considered here, whether it is generalizable out of that context, but that certainly seemed to show promising results. Less effective, again, work-focused problem solving. So this was without kind of any health support in the background, so just focusing on problem solving at work without support of health interventions as well. And in the same review that compared different modes, but simply improving clinical care alone was less effective than a sort of multi-dimensional approach, a more holistic approach. So that included comparing different medications to each other, or usual care plus. So I think the plus, it might have involved some telephone outreach, but that alone, simply improving clinical care, simply improving work without bringing them together, was sort of small to no effect for those. And also mentioning that CBT, or problem solving skills, that was work goal oriented, showed promise. And for people with a learning disability, use those terms as described only, as used in the reviews. There were some differences in how people were described in this, but I use the terms that they use. As you can see, there's far fewer reviews for interventions for people with learning or developmental disabilities. Again, there is some agreement, I think, in support again, supported employment, workplace accommodations, individual placement support again, and real work and real experience was suggested was more effective in leading to paid work. Less effective was sheltered employment. Not sure how common that is in the UK these days. This is segregated as opposed to competitive employment, usually government funded and run by non-profits. They don't tend to lead to competitive employment. So if you're sort of placed or choose sheltered employment, it doesn't lead to competitive employment outcomes. So on to our studies focus on older workers. Even less evidence we found for interventions specifically targeting older workers. They were few and far between as far as review goes. So we looked at what interventions were there. We may not be able to say too much about what is effective without looking at the evidence, but we can say something about what interventions there are. So uniquely for perhaps older workers is interventions at the structural level. So these are those aiming to either encourage older people to stay in work with incentives, or changing eligibility for retirement with raising retirement age. And we found studies, national studies at this level, but they were very, very different from one another. I have to be careful about what we can draw from that, given that I think they would what these different countries called early differed quite a bit, I think, that we might say for the UK. So there's some caution over the interventions at this structural level. Also that there may have been they certainly suggested there were interactions at other elements of the system. So interventions in one area could have somewhat unintended consequences for perhaps other working age groups. So common themes then for interventions at the workplace level tended to be around changing the work environment to meet workers' changing needs and capacities. So summarised in the one review by Parsons in 2019 that was the one review on interventions for older workers, suggesting that it's a supportive workplace and a work culture that's conducive to for workers aged over 50, feeling well supported at work. Many of the interventions were already targeted for older workers who already had a work condition. So this was about helping people with older people with a health condition manage it better in the workplace. So of course we're seeing some common themes in the types of interventions, perhaps not a surprise, as these sort of analytical categories we're using, such people with ill health and people with depression and older workers, are not mutually exclusive from one another. Most of the interventions we saw for changing the work environment specifically for older people were in Scandinavia. So again, we have to be cautious about how generalizable these interventions are in the context in which they were done. For person-centered interventions specifically designed for older workers, again, reminder that these person-centered interventions tend to be around changing behaviours, knowledge and skills. Standouts were interventions that rapidly responded to job loss. So in order to maintain motivation, there were interventions designed around job entering the market, job searching skills, peer and advisor supports, coaching, upgrading, one's job skills through career reviews, and specific skills upgrading. So again, tailored to the individual again, but customized, recognizing complexity of needs for individuals with targeted interventions to specific skills and skills gaps. And for thinking about interventions that of the workplace as a site for health promotion, so bringing healthy activities to work, assisting to making it easier to make healthy lifestyle choices at work. These again, we saw these earlier in perhaps generic workplace interventions involving exercise classes and diet advice, relaxation, CBT. And also making work a healthier place, so workplace adjustments that impact on health outcomes. And that was our whistle-stop tour of our rapid evidence assessment.
That was a complicated review, I know, and given the importance of the issue as a policy issue, it's a little bit surprising that the literature is so patchy and so scarce, and it's sort of difficult to work your way around. I think there are lots of overlaps which aren't necessarily noted in the literature. But thank you very much for summarising so well that complicated body of evidence. We'll come back, I think, for questions after all speakers have had a go, unless there are pressing issues that people want addressed. And do let me know in the Q&A or chat if that is the case. But for now, let's go on to the next presentation, which is going to come to us from Sarah Arnold. Sarah, welcome. Sarah is from the King's Fund and is going to present on the political context of policymaking around economic inactivity and health. Sarah leads the responsive policy team at the King's Fund, and previously she worked for the BMA and for the New Economics Foundation. So welcome, Sarah.
Hi everyone, thanks very much for inviting me. I think this is an extremely timely issue, with supporting people into work as well as kind of improving health, a real focus of this current government. So I'm going to talk a bit today about the political context and some of the recent developments, I guess, around economic inactivity due to ill health in particular, and what we can learn from that. So I'm going to start by highlighting, I think, how important this is as an issue. And I'm not going to bang on majorly about the stats, as I think you're going to hear quite a lot of that from others. But I think it's important to note that economic inactivity due to ill health has been an ongoing issue, particularly amongst the older age groups for some time, and will likely to continue to be an issue in the future. So I've got some graphs on the slide here kind of showing the levels of health-related inactivity that I borrowed from the Health Foundation, actually. And you can see there the middle graph is the one related to 50 to 64-year-olds, and the purple line there is those who are economically inactive due to health. So that's been going up since certainly over the last decade. And we're now at the point, I looked up the recent stats, that over 1.5 million people aged 50 to 64 are economically inactive due to being long-term sick or disabled. And I think that partly reflects a lack of focus in recent years. But just to give an idea of the scale, that's enough people to fill Wembley Stadium more than 16 times over. Just people who are economically inactive due to ill health aged 50 to 64. And it's not just a current problem, it's a future problem too. So ONS stats show that a child born today has a healthy life expectancy of just over 62 years old. And that's an estimate of how many years a child born today can expect to live with very good or good health, self-perceived. But that same child can only expect to retire, by which I mean the state pension age, at 67, or really at the rate we're going, possibly even older. So I think the link between health and employment for older people is important right now, but also a really important issue for the future. Now, the newly elected government recognises economic inactivity and ill health related inactivity as a key issue. And they've got a stated focus on missions, the first of which is to kickstart economic growth. And indeed, Keir Starmer has indicated that that's his #1 goal. And one of the strands of that is to increase the employment rate. They have a target rate of 80% of employment. I mean, that's never been achieved before in the UK. And even if you fully eliminate unemployment, you wouldn't achieve it. So there's no way that target will be hit unless economic inactivity is also reduced. We've also seen that mission filtering across government. So we've seen Wes Streeting, for example, talking a lot about how he wants the Department of Health and Social Care to be a driver of growth. And he wants to cut waiting lists to get people healthier, but also back into work. And that's a phrase he's actually repeated quite a few times. And that makes a lot of sense. There's a clear link between someone's employment status and their reported health. And unemployment has been consistently found to have a negative impact on a range of health outcomes. Conversely, of course, there's some evidence, although a bit more complicated, that having a job can be good for your health because employment's a good way of getting adequate financial resources and can be fulfilling. Although I do think it's important to note, and I'll touch back on this a bit later, that not all work is good for your health and can in some cases be harmful, for example, by causing mental and physical stress. But I'd like to explore a bit now how this has played out in the first, well, we're well past the 100 days now, 150 days or so of the new government, and how, although the ambition is there, the rhetoric may not actually match the reality so far of what is needed or what is being delivered. So I've pulled together here some of the recent announcements and suggestions we got from ministers in October relating to the health service and getting people back into work. We've got Wes Streeting's Jabs for Jobs think piece in the Telegraph, where he suggested unemployed or economically inactive people living with obesity could be offered weight loss injections to help them lose weight and get back into work. We had Liz Kendall suggesting that job coaches could go into mental health wards to visit patients. And there was also an announcement from Streeting at the Labour Party conference and then repeated in advance of the budget to target so-called surgical hit list teams at areas of high economic inactivity. And if HIT is new for you, HIT stands for high intensity theatre. And And it's a way of increasing efficiency in surgeries by running multiple theatres at the same time, with patients being prepped in one theatre whilst the surgeon's operating in the next, so consultants can simply switch over. This is something that the NHS has been talking about expanding for a little while, but the focus on high economic inactivity is definitely new. So let's take these in turn and look at some of the evidence, I think, behind them. So starting with mental health coaches on job wards, I've put a picture of a kite here because this is an example of what one of my colleagues calls kite flying. It's not necessarily backed up with loads of detail. It was just something that was said. But this was an announcement that came from Liz Kendall talking to the BBC. And she cited 2 examples of projects, one in Leicester and another in Maudsley Hospital in London, which offered employment support to people with mental health conditions living on hospital wards. However, there's absolutely no public information on the evidence of the trials. And as Mind, the mental health charity, pointed out, many people with serious mental health conditions are left more traumatized by their stays in hospital. And in order to get people to rejoin the workforce, what they need is compassionate care that truly helps them get better. So I think this shows there needs to be 2 standards for evidence on interventions that get those in ill health back into work. Firstly, does it work in terms of getting people back into work? But secondly, does it work in terms of ensuring that it doesn't worsen ill health? Secondly, we've got the weight loss drugs. And that was based off, I think, an initial conversation Wes Streeting had with the Telegraph. There was a flurry of concern at Streeting's article, citing all sorts of issues. For example, the long-term effects of some of these drugs are not yet clear for those living with obesity. Equity issues with people who are not economically inactive wanting to access the drugs but not currently being able to access them. And many people concerned about coercion and choice and whether benefits, for example, things like universal credit would be withdrawn if people didn't take up the injections if offered. That to me was quite interesting because when you actually look at the detail of what is happening, this is something that is actually having a proper trial to generate the evidence base. There's a trial, a partnership between Eli Lilly, the pharma company, and the University of Manchester in Greater Manchester over 5 years, working with around 3,000 people to test whether weight loss drugs do improve employment outcomes. So this is a chance to actually generate that evidence. So I think this is a really a good way of doing things and piloting. And then finally, we have the hit lists. And this one is particularly curious because firstly, I would say there is good evidence that the high intensity theatre approach improves efficiency without compromising patient safety. So from a health angle, this is a well-tested and well-evidenced approach. And that's based on trials in Guy's and St Thomas's Hospital, but it's been rolled out for a number of specialties and procedures. What's a bit curious is that what the government announced recently is targeting particular teams going in to try and make this happen in, they mentioned 20 specific areas. And I plotted where they've targeted those interventions on a map against economic inactivity rates in local authorities, which is what you can see in front of you. And it's clear from that map that it's not particularly well matched in terms of where the areas are targeted. So you've got lots of areas in the south that have got areas of high economic inactivity, like Dover, for example. That's one of the big purple ones at the very bottom, where there have been no kind of teams sent in. And then you've got places further in the north, for example, Doncaster in the middle there, which has relatively low rates of economic inactivity, but that has been targeted. Now, there are other waiting list interventions. So it may be that if there was something already in place, an area wasn't targeted, but that hasn't been at all clear. And so I think the government's intentions on this has not been very clear, which makes it difficult for health leaders. And secondly, if you were going to target ill health related economic inactivity, would a HIT approach or even surgery be your starting point? And I really don't think it would be. So this table here shows the main health conditions for those who are economically inactive in 2023. And sorry, I haven't pulled out specifically the older age group, but so this is everybody. But you can see, putting aside the unspecified catch-all at the top there, the top 3 reasons why people say they are, or the main condition they have related to ill health for those who are economically inactive, are not really the ones where surgery is usually the answer. The top 2 of depression and mental illness, they obviously don't need surgery as their number 1 thing. And neck and back issues are also ones where you often don't need surgery. You might need rest, you might need physio. So I think it's a bit confusing. It's also confusing because it's not clear kind of what exactly they're targeting and why. So the next slide I put here, it's meant to be a bit tongue-in-cheek, but what I mean to say is that I think there's been a lot of announcements going forwards. If the government actually wants to be effective in getting win-wins of improving health and getting people back into work, they need to think about a couple of things. And firstly, that is a better understanding of the problem. Are people primarily economically inactive because they're waiting for surgery, or is it for other reasons? Secondly, being clear on the evidence base for interventions, both in terms of their impact on economic inactivity and health, and thinking about building the evidence base where it doesn't exist. And thirdly, being clear on the messaging of interventions and clarity on what they're trying to achieve. I think that's really important when there are so many plans and new ideas flying around with the new government. And a final point that I haven't seen mentioned too much by the government, but I think is worth thinking about at the moment, is that the health system, and the NHS in particular, is one of the largest employers in the world. So it's worth thinking about what it can do to, as an employer, to improve the health of the people it employs, or other ideas like helping people find jobs within the NHS to get people back into work. I think there is definitely hope here. There's both clearly some political will behind this, and there is clearly a desire to start thinking about this more strategically. At the budget, there was an announcement of NHS health and growth accelerators to help develop the evidence of the impact of targeted action at the top health conditions driving economic inactivity. And I would hope that a key part of that is a particular consideration of the over 50s as a cohort that need particular attention as the largest group of those people. So thank you very much.
Sarah, thank you very much. That was a really helpful overview of the political context that underlies this issue. I'd love to ask you more about why you think the government has honed in on the issues that the interventions that it has. But maybe we can come back to that in the chat. But for now, let's move on, and we're going next to Emily Andrews. Emily, are you there? Emily is Deputy Director for Work at the Centre for Ageing Better. Hello, Emily. And is going to talk to us about older workers in the context of their health conditions. Before Emily joined the Centre for Ageing Better, she worked for the Institute of Government, where she led several research projects. So, Emily, over to you.
Thank you very much. Right, let me get my slides up, but I'll chat while I'm doing that, because it's so interesting to come after these 2 presentations. I'm assuming you'll shout if you can't see my slides. You know, kind of Sarah set out why this government does care about work and health. Why, you know, it's important to their growth mission. They've got to increase workforce participation if they're going to grow. And then what we've heard from Carol is a sense of the kind of interventions that might actually work to do something about this, to do something to keep people with long-standing health conditions in the workforce and then return them to the workforce when they fall out. And of course, what's so clear from this fantastic work that Carol and the team have done that I'm really grateful for, and that one existing evidence review on this is ours from a few years ago. So and I've always been, it's a really good start, but I've always wondered if there's another way of unpicking it. So that's why I'm just so grateful for this work. But what that makes really clear is that what is going to work is stuff that's really person-centered, tailored adaptations for individuals, which involves clinical staff and workplace staff. Line managers are going to be really important to this, coming together to meet the individualized needs of a person. That's basically what actually works, right? And that is expensive. And when interventions are expensive, I think there will be a tendency, and I'm already slightly concerned that there is a tendency to think that therefore to get most bang for buck, it is best to concentrate that spending on the younger age cohort, right? Because if they fall out of the workforce, that's decades that they're going to be out, right? So from a kind of economic growth perspective, from an individual suffering perspective, there's this kind of intense feeling that, right, we're so intense at that the problems are so intense that younger age group, and it's so expensive, we need to focus there. So what I'm going to do in this presentation is argue that the cohort that the government actually most needs to reach with the interventions that it's going to roll out is people aged 50 and over. And amazingly, I'm not going to be the only person saying that on this panel, which is so exciting. Number two, I'm going to be saying if those activities don't reach and support people who are in this age cohort, they will have failed. And I'm also going to say that if government doesn't explicitly work to ensure that these initiatives work for people over 50, then they won't. And as I've put in the chat, I am going to fudge. I don't tend not to use the term older workers. I use the term workers in their 50s and 60s. Some of my stuff is 50 to 65, some of it's broken down, and we can discuss more in the Q&A about why I take this approach. So here's the first reason that government needs to reach people in this cohort with their initiatives, 4.8 million people. That's around 45% of all the people who are living with long-standing health conditions are in work. Or sorry, 45%, sorry, 4.8 million people aged 50 to 64 who are with a long-standing health condition are in work, right? So we know that getting people back into work when they've fallen out is a nightmare. So we need to keep this 4.8 million group of people in the workplace, and there's a lot of them. So as well as dominating the group of people who are in work with a long-standing health condition, the over 50s also, of course, dominate the group of people who are out of work with a long-standing health condition. So there are over 1.5 million people aged 50 to 65 who are out of work due to ill health. And as a proper data viz person, I promise, I don't use pie charts. Pie charts are terrible. They don't tell you anything, except when what you want to show is that one slice dominates the whole thing. So here is this same data of all the people who are economically inactive due to ill health on a pie chart. So that's 53% of all of the people who are economically inactive due to ill health are aged 50 to 65. And that's despite the fact that they only make up a third of the workforce. So when we're talking about people who are inactive due to ill health, to a large extent, it is people aged 50 to 65 that we mean. Now, you could say this is what we expect, right? People with long-term health conditions are more likely to be over 50 and vice versa. And just because ill health clusters at a later age, you could argue that it doesn't mean that we need an age-targeted approach to supporting them. It just means that this is the group, the over 50s, who will be targeted by interventions to support people with long-term health conditions to be in work. So in a sense, any work and health initiative is de facto an over 50s initiative to a large extent. So you could stop there. But I don't stop there. I actually don't think that that argument works fully because the data suggests that there is an age effect which compounds the health-related disadvantage. So in other words, I'm arguing that there's an age penalty which goes beyond the health penalty in employment. So let's look at the health employment gap, right? So this chart is showing us right now people aged 35 to 49. So that pre-50 cohort, right? On the left, we've got the employment rate of people that in that age without a long-standing health condition. That's 90%. That's most people without a long-standing health condition in this age are in work to a large extent. With a long-standing health condition in this cohort, 73% are employed. So that's a big kind of disability employment gap. It's 18.2 percentage points. So now let's look at the 50 to 65s, 50 to 64s, sorry, on this chart. So 81% of those without a long-standing health condition in this age cohort are in work. So there are reasons that are not health related that people may be out of work at this age, right? You might have a care responsibility or you might have enough financial security that you don't need to be in work, right? So that's your 20% at the top. 81%, however, are working in this age cohort. Amongst people with a long-standing health condition in this age cohort, only 57% are in work. So that's a 25 percentage point employment gap. So in other words, people with a long-term condition are 60% more likely to be out of work if they're 50 to 64 than if they're 35 to 49. Okay, fine. That still doesn't necessarily show an age effect, right? This still could be a health effect because we know that older people are more likely to have multiple complex health conditions, which creates greater barriers to work. So inevitably then, you would think that employment rates would be lower. So that's still a health effect. That's not an age effect. It's just that the unhealthy people in this age cohort are even more unhealthy. I think that's definitely part of what's going on here, but there's still something that gives me pause. So in the labour force survey, people with health conditions get to say whether or not those health conditions are work limiting. Now, if it's the case that worse health is what's driving this higher employment gap, then you would suspect that the proportion of people who say that their condition is work limiting would grow substantially with age. But in reality, that's not what's happening. The proportion of people with a long-term health condition who say that it is work limiting is actually pretty flat across the age range, as you can see in this chart. So if it's not just a health effect driving this higher employment gap and the poorer disability employment rate amongst people over 50, I think that part of this is attitudinal. And when I say that, I don't just mean straightforward age discrimination, right? You can't have this job, or you can't have this support, or we want to get rid of you because you're older. Although there is definitely plenty of that circulating in the labour market. I think there's also a kind of paucity of imagination and a lack of understanding about what the reality of extended working lives means in a kind of age of demographic change. So there's a sort of mental model that still kind of sees 60 as a retirement age. And that means that we put less energy in trying to solve this issue for people, particularly over 60. So one bit of evidence for this is how access to work provision falls after 55 and falls off a cliff after 60. So this is the support, the government support that is to keep people in work, right? It funds various adjustments and equipment to kind of remove access barriers that disabled people face when they're just trying to do their jobs. So if we're going to keep people working into their late 60s, we need to see this ramping up, not tailing off at the end of the life course. So this is kind of medium quality as an indicator of the thing I'm trying to argue. I think even stronger is what we can say about the performance of back to work support. So we know that people in their 50s and 60s are less likely to access back to work support. And when they do, they have worse outcomes, again, particularly amongst the over 60s. So one example is that the last government put in place this Work and Health Pioneer Programme, which was specifically about trying to reach economically inactive disabled people and kind of disadvantaged groups, right? That's who it was for, reaching out to these people. Only 1 in 4 of the people who started on that programme were over 50. Overall, only 1 in 10 people who are out of work, aged 50 to 64, engage in out of work support. So people aren't engaging with these services. And when they do, they get the worst outcomes. So here's 2-year job outcomes on the Work and Health Programme, which is something different to the thing I just talked about. So confusing, but it was basically under the last government, a kind of outsourced programme from DWP to give kind of extra support to long-term unemployed and particularly people who have health barriers to work. As you can see here, right at the end, fewer than 1 in 5 people over 60 got a job outcome from the Work and Health Programme, compared to 1 in 3 people in their late 30s and even more kind of younger than that. So this is why, and I'm wrapping up now, I think an age-neutral approach to health and work isn't going to be enough, because fundamentally an age-neutral approach accepts that outcomes will be worse for people who are older. And another way of saying that is that an age-neutral approach accepts that we can and should write people off from the labour market once they hit a certain age. Now let's remember, healthy life expectancy amongst the richest decile at the moment is around 72. Amongst the poorest decile is around 53. So the people that we're talking about here aren't people who are leaving the workforce to live in comfort. The people who can least afford to leave work early are the people who are most likely to face health challenges in staying at work into their late 60s. That's why when the state pension age rose from 65 to 66, the absolute poverty rate amongst 65-year-olds doubled. And of course, by 2028, the state pension age is going to be 67. It's about to start going up again. So fine. We can accept that we can't and shouldn't put the effort needed to help people, including people with complex health needs in their 60s, stay in and remain in work. We might think it's too hard. But if we do that, if we accept this, then we cannot raise our expectations on people to work longer. So if we're not going to do better on these outcomes, then we can't raise the state pension age. And of course, that's not going to happen. There is no way that the state pension age isn't going to go up to 67, and there's no way it's not going to go up to 68. The question about 68 is when. So if the state pension age is going to go up, we need to try harder. And here's what we propose. We need the government to take an age-positive, age-curious, and age-targeted approach. So an age-positive approach means setting higher performance standards for people in their 50s and 60s. And indeed, I think it should be broken down, 50 to 59s and 60 to 65s, or indeed 66s. So all employment programs, those initiatives that are designed to retain people in work and return people to the workforce, should have explicit and high performance standards for people in their 60s. That's the baseline. I think if government sets that, the rest of the system might then start to sort of respond. The second thing that they can do is be age curious. So we need on all of these programs to have transparent age breakdowns of data being published. The reason I talk about the work and health program so much is it's just a program that we've actually got public data for at the moment. And better evaluation. You know, we heard from Carol, there's so little evidence about this. And who has the ability to gather that evidence, to do that research? It's government. They're the people who are running these programs. They have the numbers, they have the volume. They don't need to do anything different at the moment other than be curious about what's happening in their existing programs for this age cohort and how to make it better. And finally, I'm arguing for an age-targeted approach. I think that while we're waiting for that evidence, there's still enough to show that we need to try new things to get better outcomes for this age group. So that means continuing the age-specific support that the last government put in place and also try new things. If we want to do pilots, if we want to do innovation, we would only need to reinvest a fraction of the money that we will be saved by increasing the state pension age to 67. And I think there's no way not to. So there we go. That was my polemic. Thank you very much.
Thank you so much, Emily. That was a fantastic, if speedy, path through some of the really important issues. I mean, Sarah was making the point that you know, there is political will, but without better and more thoughtful intervention and more intervention, the government won't meet its economic and productivity targets and missions connected to that. And I think you were also saying that, but bringing in a really interesting dimension of government's commitment to social justice and inequality, and how that also figures here. And unless there are different types of interventions, different focus for interventions, those won't be reached either. So thank you very much for that. We're going to move on to our final speaker, who is Daniela Silcock. Hello, Daniela.
Hello.
Daniela, hi. Daniela is Head of Policy Research from the Pensions Policy Institute. And Daniela's going to talk to us about the role of pension policy in creating problems and potentially potential solutions to the issues of economic inactivity. Daniela, over to you.
I thought it would be useful just to start with what exactly is economic inactivity, because it's one of those really interesting labels which a lot of people could fall into but don't. So you might be economically inactive, but you know, in some sort of recognized activities such as seeking work. So it's very specifically people who are not in work and not looking for work. And whether or not that's an issue is something that can be debated, and why it's an issue and who it's an issue for. And I think the speakers today have made some really, really good points around that. So I'm just going to bring you back here to the actual stats on economic inactivity. If you're interested in these, which come from ONS, they actually go back a further 20 years, but I thought that might be a bit confusing, so I'm just showing you the last 20 years here. You'll see that for all age groups, there has been a steady decline in economic inactivity. So more people in all age groups have been in work at most times than previous generations. But then we saw a peak for people of specific ages around COVID, so around 2021, 22. So what I've done is I've isolated on the right-hand side the age groups 50 to 54, 55 to 59, and 60 to 64. So older people, basically, people aged 50 to 64, but people who aren't yet claiming state pension benefits. So you can see here there's a bit of a rise by 1 or 2% for each of these groups that were experienced during and after COVID. And I'm going to go into a bit more detail about why this is happening and why we care about it. But I just thought it was really interesting to separate out men and women and see what the peaks are for them. And what actually struck me was how many more women are economically inactive at older ages than men are. So we've got women aged 50 to 54, almost 20% are economically inactive already. And for men, it's just above 10%. Then we've got around 30% of women aged 55 to 59 compared to men of 55 to 59, where it's around 20%. And then almost around 50% compared to 40% at ages 60 to 64. I suspect that these kinds of stats will start to change. There'll be more convergence in future because part of this is around women in the workplace generally and older women and the experiences they have had in the workplace. You see a lot more women of younger ages working than previous generations. So women who've already been working are more likely to continue working. But these stats also show quite a lot about how women end up providing care for family members more than men do. And that's one of the key reasons for leaving the labour market. So what's going on here? Well, there have been some very interesting health effects related to COVID. So while people might have lost their job or been put on furlough, we found that actually health decreased, or health conditions decreased more rapidly during COVID. And it may have been the case that some people left work, were not in ill health, and then when it came time to start thinking about returning to work, a lot more of them were in health. That's not easy to say, in ill health. And that's partly because of pandemic effects, not just the effect of the disease itself, but the isolation and the stress associated with it. We saw definite increases in physical and mental health problems among older people and among the population generally. But what we also found was that there was less access to healthcare. People couldn't leave their house. The NHS was stressed. So we had more people being poorly, and we also had fewer people being able to access healthcare, which meant that these conditions were more likely to become entrenched. Generally, therefore, more increases in poor health and more increases in people actually providing care at older ages. There were a few other cultural effects, and I think it was quite interesting because when we were looking at this last year, someone had done some international work and found that while people in the UK are particularly negative about their jobs. Other countries such as Germany or the US, they find people are generally quite positive, and there's almost a cultural attitude of positivity. So we were more likely to find here that people just didn't want to go back to work. So very interestingly, ONS found that 66% of those aged 60 to 65 who left work during the pandemic just thought, you know what, this is great, I don't want to go back to work. They didn't have that keenness. And then there's some other effects. So some people just felt like they were in a good financial position. So particularly homeowners, which there's much more of in older age groups than there are in younger age groups, or those who are quite financially comfortable, were more likely to stay out of work. So the reason why this matters for pensions, and I am a pensions person, is that the longer you stay out of work at older ages, the less you are contributing to your pension. That's one thing. And the second thing is the more likely you are to start depleting your savings to support yourself at older ages, but prior to state pension age, therefore reducing the amount of income that you might have in later life. And what we have been seeing is that more people have been accessing their pension savings to support themselves at older ages. And that seems to be correlated with these increases in economic inactivity among older people. So I think in some ways policy almost encourages economic inactivity for older people. And there's quite a few, I mean, inadvertently, of course, the government doesn't really want this, but there are a few policy measures that together almost create a perfect storm, and then some demographic effects. So COVID-19 to some degree has prompted a rise in this and prompted there to be more attention being paid. But we're only talking about rises of around 1%. We actually have still relatively high levels of economic inactivity among people of older ages. So there are a few things that have happened all at once that, working together, almost promote this kind of behavior. One of those is that fewer people are saving into defined benefit schemes. And that's interesting or relevant because people are now saving into defined contribution schemes, which allow much more freedom. So if you're saving into a defined benefit scheme, the age at which you access will be set. You can maybe access early at a discount, but it's not easy to just flexibly access. So we've seen the decline of defined benefit and many, many more people. We've got about 14 million people now saving into defined contribution savings. Alongside that, the pension flexibilities were introduced in 2014. And these mean that people can access their savings from age 55 flexibly. It used to be the case that you had to buy an annuity, but now you don't need to. So there's that pot of cash there for people who think, I don't want to go back to work, or I don't feel well enough to go back to work, or I have to provide care to my partner and I don't have the time to go back to work. There's that really enticing pot of money. And then we've got this legacy policy, which made sense 20, 30 years ago under DB pensions, but doesn't really make that much sense now, where you can access your tax-free lump sum. So if you've got a DC pot of £100,000, at age 55, you can take 25% of that tax-free and do whatever you want with it. And people get wake-up packs between the ages of 50 and 55 telling them, oh, you can do this, you can access this money when you're 55. So if you're struggling and in a particular situation, you might think, well, this seems like a godsend, or why wouldn't I do it? There's a couple of issues with that. One is that's money that you will no longer get any compound interest on, and you could be saving for another 10 years or so. The other thing is, once you take that 25% tax-free lump sum, you have to take the rest out and put it somewhere. So that could be in an annuity, though it generally isn't. It could be in a drawdown account that gets reinvested that you can take money from. But these generally aren't invested in the same long-term way that pensions are. We're talking about already having less of your money in there because you've taken 25% out. And anyone who does this may, especially if they're economically inactive, say, well, I'm done contributing to my pension, I will live off of this. It's become even more complicated as well, because we're seeing people in their 50s and 60s having more calls on their income from younger relatives and older relatives. So helping children, grandchildren out with house purchases, university, supporting them while they come home and live with you, as well as needing to provide more care for parents and potentially financial support, which again makes that flexible access and the 25% tax-free lump sum more attractive. And supporting all of this, as Emily mentioned, is state pension age rises. It was 60 for women until 2010. Now it's 66 for women, potentially rising to 67 by 2028, though they're going to do a review. So there's this huge period of time where people think, well, I need to fill that up and then I'll get my state pension, potentially not realizing how incredibly low their state pension is. So you may be in a position where you actually have a sufficient amount of money if you continue to save, if you were able to continue working and contributing, but you use that up and then you reach state pension age and suddenly you think, well, I can't really cope on, you know, about £200 a week. It's not very much money that you get from the state pension. So in some ways, policy is actually encouraging economic inactivity. And I think there are some real issues here, specifically with pensions and pensions communication, in that pensions are incredibly complex. People don't really understand what they're doing or how to access them or how to think about the future risk of longevity, of compound investment, of inflation, of further needs for care in later retirement, which is why it actually seems probably like quite an incentive. I've probably gone over my 10 minutes, apologies for that. So 3 conclusions. I feel like policies are actually encouraging economic inactivity, and that specifically isn't being addressed by government, probably because there's lots of different policy areas, and no one's really thinking cohesively about that. The real danger is people having very low incomes in future as a result of what they're doing today. And if we are going to prevent those aged 50 to 65 who are economically inactive from suffering financial deprivation in the future, we actually need to do some action now. And some of that is policy-based, but probably some of that is also education-based.
Daniela, thank you so much. You brought a whole other dimension into the discussion, and a really important one, and quite sobering. Yes, listening to you. We have run over on the presentations, but I'm sure you'll all agree that each of them were incredibly interesting and brought something new to this discussion. But we have got now some time for questions and inputs from attendees, the audience. So I'd encourage you to use the Q&A in the chat if you want to do that.
While you're having a look, I can answer the question about how we define older workers.
Thank you.
Shall I start there? Because obviously this is something that we, you know, my whole team at the Centre for Ageing Better, our mission is to create fair access to work for people in their 50s and 60s. So this is an issue we think about a lot. And you will have noticed in my presentation, I sort of switched around a bit. Sometimes I'm talking about 50 to 66. Sometimes I'm talking about 60 plus. There is definitely something that is different about 60 plus. The problem is, like, getting a clear, you know, cutting between the 50 to 60 group and the 60 to 66 group. On the one hand, I think it is the correct way forward. On the other hand, it kind of elides the fact that the challenges of aging hit people at different ages. And again, this comes back to healthy life expectancy, that if you are poorer, you are likely to kind of be be dealing with the physical illnesses that we associate with old age younger, indeed in your early to mid 50s. And so if we just always talk about 60 plus, which I think I do, because it shocks people a bit more because it feels like a bigger change. That's one of the reasons why I talk about 60 plus. But I think there are other reasons to do that. But some people who are in that position at 63, there might be other people who are in a really similar position at 53. And again, we know that from the work that we do with people who are long-term unemployed and trying to get back into work. So it's kind of like, on the one hand, I think splitting up is helpful, but on the other hand, that then we miss then all the other variation between those groups. So that's a really unfortunate answer, but there isn't a clear-cut way of doing it.
It's a reasonable answer. Thank you very much for that. Bethan GLA asked, do you think the Work Well programme will work with older workers better than Work and Health Pioneer programme has, following Dr. Andrews' comments? Someone want to come in on that?
I mean, I think it only will if someone tries to make it so. And I have no indication that they will, right? This is why standards are so important to me. I think, as far as I know, there are no age-specific targets in Work Well, so there's no reason to believe it will be better. If it is, that will be interesting. That will tell us something about this age cohort. And we will hear, that's where my evaluation point comes in, is that if the government evaluates Work Well properly with an age lens, we will find out. But unless we try and make it work better, I've got no reason to believe it will. The thing I think does have legs on that front is what was universal support and is now, who knows what's going to happen to universal support, which is much more involved, where there's more emphasis on the placement element of brokering people into jobs. And again, the problem we have with this cohort is employer attitudes, can be very poor and very dismissive towards people, again, particularly people over 60. And so people need to have a chance to show what they can do. And that's also important for our own confidence as well. So I think any program where there is an element of really deliberately putting people in work for a period of time quickly, rather than focusing on support for the person, my feeling is that that's likely to have more legs for this cohort.
I wanted to come back, actually, just a question to Daniela, while other questions are coming in. Daniela, you made reference to the increasing number, I think, of pensioners who were taking up the ability to access that pension pot that's been made available via government changes in government policy. Are there numbers around that?
Yes, there are. So what I've cited in the slide is from the Financial Conduct Authority's retirement income review, which they do every year, and they've actually tracked it. It's gone back quite a bit. So let me just have a quick look. So it's gone up by 18% and then 20% in the last 2 years. So that's in 2022-23, that was 7,309 and 739,000 pensioners, and in 2023-24 that was 885,000. So yeah, it's going up every year, and that data is actually really useful because it will break it down by age as well, and try and look at other financial circumstances. So that's FCA's retirement income review.
Great, thanks so much for that. Okay, we've got a couple of other questions. Susan Connolly says, how do we encourage employers to be age curious, which is such a lovely term, and really focus on collecting data on older workers, recruitment outcomes, retention, exit interviews, etc. We need evidence of discrimination to support the lived experience. Any comments on that?
Indeed, this is a question we have. So we've tried, we were like, well, we've just got to try and do it. So we run a program called the National Age Friendly Employer Pledge, which is for employers who are committed to doing better on the retention and development of workers in their 50s, 60s and beyond. And I added the and beyond recently in recognition of the number of people who are working into their 70s by choice more often, but there is a growing number of people who are who feel financially they have to work into their early 70s, finding it difficult to manage on their state pension. So we run this program. We've got 460 employers who have signed, been going for 2 years. What I would observe is that there are 2 types of employers who are interested in it, 3 types. You've got employers who are dealing with big recruitment challenges, hospitality and health and social care. So they really want to make their recruitment practices more inclusive because they want to get more people in. There's places like construction, local government to an extent, where they're interested in retention and how to make the most of their people so that people don't leave prematurely when those skills could be kept in the workplace if they found the right way to do it. And then you've got like hearts and minds people who think it's the right thing to do, kind of charity sector. Obviously, it's a coalition of the willing. And I think the thing that makes a difference ultimately to a lot of businesses is the kind of bottom line, which is what's going on in hospitality. But there's still something else, because retail got no interest in old workers. They've got recruitment problems. They don't want it. They only think younger workers are their cohort. So there is, we champion the value of older workers. We champion the business case. There's loads of that on our website, and we're kind of building this movement of employers who are learning how to do this better and trying to do it better. And we also are campaigning. We run a national campaign called the Age Without Limits campaign to try and tackle ageist attitudes in society. And we gather in a lot of stories about age discrimination in the workplace there. So if you've got something to share, please have a look at that.
Rona Topaz asked, has any research been done on making employers more flexible to accommodate neurodiversity or people with chronic illnesses? The onus should switch to them as opposed to painting long-term unwell people as leeching from the welfare system. So I'll leave that for people to come to. Does anyone have thoughts on the neurodiversity issue raised by Rona Topaz? Are there any references that we could point Rona towards?
I mean, I can't point towards references, but I can say what's very interesting in the ED&I space, in my experience, is that neurodiversity is coming higher up on the agenda. And why I think that's incredibly positive, it's not only because it creates more support for neurodiverse people, but also neurodiverse inclusive practices are like gold standard inclusive practices. I think if you have a neurodiverse inclusive recruitment process, that is going to be definitely old worker friendly, and it's probably going to support like most people. I think that's how you have an inclusive process. Chronic illness, however, much harder, right? Because that's about health and well-being support being something that you do over and over again. It's not something that you just do once. And I think that's one where we've still got more to do on getting employers to train their line managers to be willing to keep being flexible with people as their needs change. But unlike if you're an employee who's done it, you know how worth it is.
That seems to intersect with the point made, it was Daniela, you made the point that we in the UK have a particularly perhaps negative attitude to work, particularly as we get older, it seems. And I just wondered are there any indications that the kind of things that Emily was talking about, that others have talked about in terms of kind of creating a positive work environment and being flexible and adaptable, are those features of other work environments in a way that they aren't in the UK? Is there a particular issue with work environments in the UK?
I mean, a work environment is really the sum of the people who work there, isn't it? I do wonder if there will be intergenerational changes, but it's very interesting because culturally we are quite different from a lot of other places. It's not just about negativity about work, it's also there's a lot of inertia around financial decision making. So I think there's quite a sort of apathetic and negative attitude to a lot of life decisions. We can foster more positive views, obviously, and that makes sense. But I also think the question for policy is, how do we work with people? So if we understand that people are more disposed to be negative, more disposed to be apathetic, how do we use that? And for example, in pensions, we've used that by having people automatically enrolled into pensions because they're less likely to make a decision. So that sort of harnesses the inertia. And it's shocking the amount of people who don't opt out compared to where this policy has been in other countries. I mean, it really does play out that that's who we are as a people. So I wonder if there's something about harnessing inertia, or even harnessing negativity to turn it into a positivity that can be used, because the more you work with people's natural attitudes and proclivities, the more likely you are to get success.
Monica says, any good practice you can signpost to support older workers with long-term conditions at work?
Yes and no. Again, if you have a look on the Age Friendly Employer Pledge, we've got a set of kind of getting started guides. One is health support for older workers. But basically what it says is you need good health and wellbeing support. You need your line managers trained on workplace adjustments and health and work conversations. And you need to create explicit opportunities for people to disclose early, because this is one of the big challenges, is that people don't disclose. No, people of all ages don't want to disclose to their employers, but it can get particularly challenging as we get older, because you think you're going to get written off as old, and rather than supported. So you need, ultimately you just need, again, those good processes, good line management, good opportunities to have these conversations, lots of frequent check-ins around adjustments to make sure that they keep getting better, but then also lots of explicit messaging that you are positive about older workers in your workforce, so that people don't have that fear.
That's great. Thank you, Emily. So just, I wanted to come back to the question I was going to pose to you, Sarah, which is, there's a theme here emerging very clearly, that more holistic, responsive, flexible policy interventions are really what's going to cater to older people in the workforce, or what's going to have success. But they stand in contrast to the sorts of policy interventions that you were outlining, I think. And I just wondered if you could say a little, if you have thoughts about why the government has taken the direction it's taken in terms of early policy interventions, at least.
Sure. I mean, I would say it is very much on the early side, as you said. So yeah. I think partly it's a function of I think maybe, as you're saying, the lack of really clear evidence that's kind of really out there on what actually is the right thing to do. So I think some of it is them wanting to do stuff and just getting on and doing stuff. And we are starting to see more in the background, lots more kind of plans and kind of thinking about the evidence base as well. Secondly, I think there's also quite a lot. I mean, the government tends to work in silos, doesn't it? You have government departments that are very, very siloed. And that can be a real challenge. I think that's almost what's quite positive about this kind of mission-led approach that this government's trying to take. But again, it's very new. I think it's taking some time to embed in. I think what we're seeing here is lots of other government departments trying to show how they're contributing to the growth mission, particularly because, I mean, we've just had a budget and we're about to have a second stage, kind of a comprehensive spending review in the spring. But there's a lack of, we're in a constrained fiscal environment. Government departments are kind of wanting to show that they can create that growth so that they can get that funding. So I think that's why we're seeing some departments kind of showing how they're contributing to the growth mission. I think a bit of reciprocity is something I hope we're going to see more of going forwards. And as I think I said at the end of my talk, there is, I think, some optimism to think that the more joined up thinking is starting to happen. The government announced they want to look at kind of NHS health and growth accelerators, and the idea of that is to look at specific local areas and how can employers, but particularly the health system and the work support systems, kind of come together to support people back into work, hopefully in the person-centered way and evidenced way that we saw at the kind of the start of these kind of presentations. I'm hopeful anyway.
Thank you very much. And that seems to me to be a very good place to end our discussion, actually, on a hopeful note and an optimistic note. I do just want to thank again all our speakers. They were really fantastic presentations. I think just very informative and very evidence-based, which is wonderful. As Elliot's posting in the chat, you can find details of some of the publications mentioned and of IPPO work on the links that he's provided. So do please do that if you're interested. And it just remains me to thank everyone for participating, for asking such great questions, and again to our speakers, thank you very much.